Welcome to this deep dive into angioedema and anaphylaxis, really designed from the ground up for the critical care environment. We're going to go beyond the basics, dissect the core mechanisms, and master the advanced pathway-specific strategies you absolutely need at the bedside.
Okay, so here's our game plan. We're going to start with the single most important concept, the two distinct pathways of angioedema. From there, we'll get into the weeds of anaphylaxis, that classic histamine-driven emergency. Then we'll pivot to the bradykinin syndromes, which are so often misunderstood. After that, we'll run through the diagnostic gauntlet, lay out the specific therapeutic strategies for each pathway, and wrap things up with some key ICU scenarios and a look at what's coming down the pike. Let's jump in.
All right, before we go any further, this slide right here is the whole ball game. If you get this one concept, everything else falls into place. This fundamental divide dictates your every move. On one side, you have your histamine-mediated pathway. Think classic allergy. You've got hives, you've got itching, it happens fast, and it responds to our standard toolkit: epinephrine, antihistamines, steroids. But on the other side, you have the great mimic, the bradykinin-mediated pathway. The number one sign? No hives, no itching. It comes on slower, sure, but here's the critical part for us in the ICU. It is completely refractory to standard anaphylaxis therapy. You can give all the epinephrine you want, it will do nothing. Getting this distinction right from the second you see the patient is the absolute bedrock of what we're about to cover.
So let's start by really building out that foundation. We're going to look at the two distinct mechanisms that actually drive the swelling, because understanding the why behind those leaky vessels is the only way to choose the right treatment. So what even is angioedema? At its most basic level, it's just leaky blood vessels. Fluid is pouring out into the deep layers of the skin or into the tissues of your airway or your GI tract. It's self-limited, it's localized, and it's not like the pitting edema you see in heart failure. But while the physical result is this fluid extravasation, what we really care about is what caused the leak, because that's the fork in the road that separates a histamine problem from a bradykinin problem. The histaminergic pathway, this is the one we're all familiar with. It's the classic allergic reaction. It's all about mast cells and basophils getting triggered and degranulating, basically dumping their entire payload of inflammatory chemicals. This can be an IgE-mediated thing, like from a peanut allergy, or it can be from drugs like opioids or IV contrast that just directly poke the mast cell. Either way, those cells release a flood of preformed mediators, and histamine is the star of the show. It hits H1 and H2 receptors, vessels dilate, they get leaky, and boom, you've got hives and swelling. Now, in complete contrast, the bradykinin pathway is not an allergy at all. It's an enzymatic cascade that has gone completely haywire. It all stems from a dysregulation of what's called the kallikrein-kinin system. Normally, you've got enzymes like angiotensin-converting enzyme, ACE, that act as the brakes on this system, breaking down bradykinin. But when those brakes fail, either because of a genetic problem or because you gave a drug like an ACE inhibitor, the system runs wild. Enzymes like factor XIIa and plasma kallikrein just go to town, churning out massive, uncontrolled amounts of bradykinin. And bradykinin is an unbelievably potent vasodilator, causing profound, prolonged, and very dangerous swelling. Okay, so let's lock this in. Angioedema is fluid leaking from blood vessels. That leak is caused by one of two pathways that do not overlap: histamine or bradykinin. Your first decision point right at the bedside is the skin. Do you see hives and itching? If yes, you are on the histamine path. If the answer is no, you must consider the bradykinin path. Histamine is about angry mast cells. Bradykinin is about an out-of-control enzyme system. Nailing this distinction from the get-go is the absolute cornerstone of everything we do next. So let's zoom in now on the most severe, most dramatic version of that histamine pathway: anaphylaxis. This is the systemic, life-threatening emergency that happens when mast cells all over the body activate at once. We make the diagnosis of anaphylaxis clinically, using criteria like those from the NIAID. Acute onset involving skin or mucosa, plus either respiratory problems or drop in blood pressure, that's a slam dunk. But here is the critical, can't-miss pearl for the ICU. Somewhere between 10 and 20% of patients having full-blown anaphylaxis have absolutely no skin findings, none.
They can just show up with isolated hypotension or bronchospasm, which makes the diagnosis a huge challenge and totally dependent on your index of suspicion.
The clinical picture of anaphylaxis, all that chaos, is driven by a storm of chemical mediators. And it's not a single event. Think of it as a two-phase assault. First, you get the immediate release of preformed mediators that were just sitting there in mast cell granules ready to go. This is your histamine, your tryptase, and other enzymes. That's the first punch. But it doesn't stop there. That initial activation kicks off a second wave. The body starts synthesizing brand new mediators like prostaglandins, leukotrienes, and platelet activating factor, or PATH. These guys are responsible for sustaining the reaction and making it worse over time.
Now, this is really cool. The difference between the molecule that causes the problem and the one that proves it happened. Histamine is the main culprit for the acute symptoms. It hits the receptors, causes the leaky vessels, the bronchospasm. But its half-life is incredibly short. We're talking minutes. By the time you draw blood, it's often long gone. This is where tryptase becomes our hero. Tryptase is the most abundant protein in those mast cell granules, making it a fantastic biomarker. And, critically, its half-life is much longer. It peaks 1 to 3 hours after the event. It gives us a diagnostic window. So think of it this way. Histamine is the hit-and-run driver, but tryptase is the license plate number we can check later. All right, let's put this into practice. You've got a 60-year-old guy collapses after a bee sting. He's hypotensive, tachycardic, no hives. There's a prodrome of nausea and pallor. So when you're thinking through your differential, what's a really common mimic you have to rule out? The answer is B, vasovagal syncope. Both can have a trigger and hypotension, but the heart rate is your key differentiator. Vasovagal syncope gives you hypotension with bradycardia. Our patient is tachycardic, which should keep anaphylaxis at the very top of your list, even without the hives. So the big take-home points for anaphylaxis. First, trust your gut. It's a clinical diagnosis, and you don't always get skin signs. Remember, it's a storm of both preformed and newly made mediators. Tryptase is your key lab to prove it happened later, and you should always draw it. But treatment with epinephrine cannot wait for a lab result, ever. The differential is wide, but always check the heart rate to rule out vasovagal syncope. And finally, never, ever forget this. In study after study of people who die from anaphylaxis, the single most consistent finding is that they didn't get epinephrine soon enough.
Okay, let's switch gears completely and cross over to the other side of the pathway. We're now talking about the bradykinin-mediated syndromes. These are absolutely essential for us as intensivists to recognize because they are the great masqueraders. They show up with terrifying swelling, but they will not respond to your normal anaphylaxis playbook.
This is the scenario you will see. A 72-year-old on a drug that messes with the raw system here in RNI, and they develop this massive tongue swelling. You do the right thing for anaphylaxis, you hit them with epi, Benadryl, and steroids, and nothing. Absolutely nothing happens. The tongue just keeps getting bigger. That clinical picture, the isolated angioedema, the complete failure to respond to your standard drugs, that should be a blaring siren in your head that you are dealing with a bradykinin-mediated process.
So what is actually happening here with ACE inhibitor angioedema? Well, ACE is one of the main enzymes that chews up bradykinin. So when you block it with a drug, the body has to rely on its backup systems. These are other enzymes like APP, DPP4, and NEP. The problem is, if a patient has some underlying weakness in these backup pathways, and then you take away their main pathway with an ACE inhibitor, you've created a perfect storm. The main road for bradykinin breakdown is blocked, the side roads are jammed, and bradykinin levels just go through the roof, causing angioedema.
What I love about this slide is it really tells the story of this multi-hit hypothesis. Yeah, you see the usual suspects: age, female sex, smoking. But look at the medications. If your patient is also on an mTOR inhibitor like sirolimus or a DPP4 inhibitor for their diabetes, the risk skyrockets. And it makes perfect sense, right? A transplant patient on sirolimus already has lower DPP4 activity. Then you add an ACE inhibitor on top of that, you've just knocked out 2 different bradykinin degradation pathways. Of course they're at high risk. Same exact logic applies to the RNAs, like Entresto, which directly inhibit neprilysin, another one of those key backup enzymes. Okay, this right here is a clinical pearl that can literally lead to a life-saving diagnosis. When you have a patient, they're over 40, they're having these episodes of new onset recurrent swelling without hives, and they are not on an ACE inhibitor, your alarm bells for acquired angioedema, or AAE, should be going off like crazy. This is a rare syndrome where the body starts chewing up or inactivating its own C1 inhibitor, a key brake on that kinin system. And the reason this is so critical is that AAE is very, very often a paraneoplastic syndrome. The swelling is the first sign of something much more sinister.
And this chart shows you exactly why that workup is so non-negotiable. Look at these numbers. Up to 80%, 4 out of 5 cases of AAE are tied to an underlying B-cell problem. We're talking non-Hodgkin lymphoma or a monoclonal gammopathy like MGS. Another 10% are linked to autoimmune diseases. This means the angioedema is often the presenting sign of an underlying cancer. Recognizing this connection in the ICU can be the first step to diagnosing a treatable malignancy. So the crucial take-home from this section is simple. If your patient has angioedema without hives, you have to stop thinking about allergy and you have to start thinking about bradykinin. Your brain needs to immediately go to ACE inhibitor-induced angioedema and acquired angioedema. Remember, this swelling will laugh at your epinephrine. ACI-AE is about broken down breakdown made worse by other drugs. AAE is new onset swelling in an older adult that should trigger an immediate hematology consult to look for cancer. All right, let's run the diagnostic gauntlet. We've talked about the 2 pathways. Now let's talk about how we actually use labs to prove which path we're on and figure out exactly what's going on.
So here's your patient. 50 years old, recurrent isolated swelling, no hives, no family history. What's the very first test you order? Well, we know it's probably not histamine, so tryptase isn't the best first move. C1 inhibitor function is more of a confirmatory test down the line. Gene sequencing is way too specific for a first step. So the best, most cost-effective initial screening test to start heading down the bradykinin rabbit hole is a complement C4 level. Why? Because in both hereditary and acquired angioedema, where C1 inhibitor is the problem, the complement cascade is constantly activated, chewing up C4. So it's going to be low. The answer is C. Think of this table as your diagnostic roadmap. Suspect anaphylaxis? Send a tryptase. Got isolated angioedema? Start with C4. If the C4 comes back low, you confirm with C1 inhibitor function and antigen levels. And then you order the single most important test to tell the difference between hereditary and acquired forms, the C1q level. This is the critical differentiator. And here's why. In acquired angioedema, the underlying lymphoma or autoantibody is consuming the entire C1 complex, which drags the C1q level down with it. So if you remember nothing else from this table, remember this. In hereditary angioedema, C1q is normal. In acquired angioedema, C1q is low. That one lab value changes everything. And here is one of the most frustrating but important pearls in this whole talk. You cannot test for ACE inhibitor angioedema. There is no lab test. It's a diagnosis of exclusion, plain and simple. You make the call based on the clinical story, isolated swelling, no hives, patients on an ACE inhibitor. The diagnosis is only truly confirmed when you stop the drug and the attacks stop happening. And you have to warn the patient that it's not always an instant fix. They can have breakthrough episodes for weeks or even months after stopping the pill. So let's recap the diagnostic algorithm. Your first question is always, are there hives? Yes, think histamine. Draw a tryptase. No hives? Think bradykinin. Start with a C4 level. If that C4 is low, you move on to C1 inhibitor levels and a C1q. And let's repeat that key point again. A low C1q is the specific hallmark of acquired angioedema. That one lab results is your trigger to call heme/onc and mandate yearly screening for a B-cell cancer for the rest of that patient's life. Okay, now we get to the fun part, management. This is where the rubber meets the road, where all this pathophysiology we've been talking about translates directly into life-saving actions you can take right now. For anaphylaxis, the order of operations is absolutely non-negotiable. Step 1, and there is no step 0, is intramuscular epinephrine. 0.3 to 0.5 milligrams of the 1 to 1,000 solution right into the thigh. And let me be clear, in the setting of anaphylaxis, there are no absolute contraindications. Give the epi. After that, assess the airway, give oxygen, and be ready to intubate early before you lose the airway completely. Next, position the patient. Lay them flat, get their legs up. For hypotension, start pouring in crystalloids.
It's only after all of that is done that you can even start to think about adjunctive therapies. Antihistamines and steroids might help with the skin and may prevent a biphasic reaction, but they do not treat shock or airway obstruction, and they must never delay epinephrine.
This is a critical point for any of us working in an ICU. What if you've given multiple IM shots, you're pouring in fluids, and the patient is still in shock? The next step is an intravenous epinephrine infusion. You start it low and you titrate it to effect. What you absolutely under no circumstances do is give IV bolus epinephrine. The risk of a tenfold overdose of causing lethal arrhythmias or catastrophic hypertension, it's just way too high. If you need IV epi, it has to be a drip, period.
Now we pivot to the bradykinin pathway. And this slide might be the most important one in this entire section. Because if you get this wrong, your patient could die. For bradykinin-mediated angioedema, your standard anaphylaxis drugs are useless. I'm going to say it again, they will fail. You have to completely switch gears and use therapies that target the kallikrein-kinin system. This means things like C1 inhibitor concentrate, icatibant, ecallantide, or in a pinch, fresh frozen plasma.
So let's break down your options. For HAE or AAE, C1 inhibitor concentrate is a great first-line choice. You're just replacing what's missing. Icatibant blocks the bradykinin receptor, and ecallantide inhibits the enzyme that makes bradykinin. Both work well for HAE/AAE. Now here's the big controversy. Icatibant for ACE inhibitor angioedema. The mechanism makes perfect sense, but two large, well-done randomized trials showed it was no better than placebo. So the evidence does not support its use there. This leaves us with supportive care and, as a rescue therapy, fresh frozen plasma. FFP contains the enzymes that chew up bradykinin, so it can be life-saving in severe ACI-AE if you have nothing else. But be careful. In HAE, FFP can paradoxically make things worse because it also contains the precursors to bradykinin. It's a last resort, really only for ACIE. Let me leave you with one final, terrifying pearl on management. In anaphylaxis, patients can lose up to 35% of their circulating volume into their tissues in minutes. If you then let a hypotensive patient sit up or stand up, all the blood pools in their legs, venous return to the heart plummets to zero, and the heart is left beating, but completely empty. This is the empty ventricle syndrome. It leads to PEA arrest and death, and it is completely 100% preventable. Keep your hypotensive anaphylaxis patients lying down with their legs up.
Okay, let's recap management. It's all about matching the treatment to the pathway. Histamine gets epinephrine, first, last, and always. Refractory shock gets an epinephrine infusion, not a bolus. Bradykinin angioedema gets pathway-specific drugs because the standard stuff will fail. For HAE and AAE, you've got C1 inhibitor and the others. For ACE inhibitor angioedema, it's supportive care, maybe FFP, but not icatibant. And let's repeat it one last time. Remember the empty ventricle syndrome. Never let a hypotensive patient sit up. Get the stuff right, and you will save a life.
All right, to wrap things up, let's touch on a few high-stakes scenarios, talk about patient outcomes, and then take a quick peek at the really exciting future of treatment in this field. A key thing to remember after you've successfully treated anaphylaxis is the risk of a biphasic reaction. This is when symptoms come roaring back hours later, even without any new exposure to the trigger. The risk is all over the map, somewhere between 1 and 23%, and it can happen anytime in the next 72 hours. This is why every single patient treated for anaphylaxis needs to be observed. If they had a really severe reaction, needed a lot of epi, or the trigger was something they ate, they're at higher risk and need a longer observation period. Think at least 8 hours, maybe even up to 24. Your job is not done when the swelling goes down. The discharge counseling you give to a patient with ACE inhibitor angioedema is profoundly important. You have to tell them they have an absolute lifelong allergy to all ACE inhibitors. You have to warn them they could still have an attack weeks or months from now. And critically, you have to tell them they can never take an ARNI, like Entresto, because it hits a similar pathway and carries the same risk. Looking at the risk factors for death from anaphylaxis is really looking at a list of preventable tragedies. The single biggest risk factor for a kid dying from a food allergy is having poorly controlled asthma. Across the board, delaying or not giving epinephrine is a constant theme. Misdiagnosing it as just an asthma attack, letting a patient stand up on their hypotensive, these are all deadly mistakes. And of course, IV meds and insect stings cause the fastest, most severe reactions.
Now, let's look at the future. Because for bradykinin-mediated angioedema, it is incredibly exciting. We've already moved to amazing long-acting subcutaneous drugs for prevention, like lanadelumab. Coming very soon are oral, on-demand pills that can stop an attack in its tracks. And then, on the horizon, is the Holy Grail, a potential one-time cure. There are therapies in trials right now that use CRISPR gene editing to go into the liver and permanently turn off the gene that makes the precursor to kallikrein. A single infusion, and patients are seeing a greater than 90% reduction in attacks. It's just revolutionary.
And this really brings us to the larger implication, which should give all of us chills. The incredible success we're seeing with gene therapy and a rare disease like HAE, it's more than just a win for those patients. It is a massive, world-changing proof of concept. It's showing us that a new class of genetic medicines is here, one that could one day completely change how we manage countless other devastating genetic diseases that are expressed in the liver, the very diseases we struggle with every day in the ICU. The future of medicine isn't coming. It's arriving.